Dr. Liu.
Thanks, Dr. Coate. Appreciate it. And I will consent to the recording. Okay, good afternoon, everybody. Thanks for joining. And so like Dr. Coate mentioned, I'll be reviewing intracranial vascular malformations. And as we all know, these exist on the differential for sources of intraparenchymal hemorrhage, which is obviously a pathology we see very often here at Harborview. But once identified, are often quickly directed, shunted, no pun intended, to our neurosurgical colleagues. But I think it's important for us as neurologists to review them with regularity, to be able to recognize them on imaging when we encounter them in a workup, and also understand some of the broader concepts behind what goes into managing them based on the largely observational data that we have. So these are the 5 I'll be reviewing: arterial venous malformations, or AVMs for short, dural AV fistulas, cavernous malformations, or CAV-MALs for short, developmental venous anomalies, or DVAs for short, and finally capillary telangiectasias. And each are interesting topics worth like several hours in and of themselves. But for the sake of time, I'll be taking kind of a sampling approach of the main concepts behind each of them that I think are helpful from a clinical viewpoint of a neurologist. And given the last 2 DVAs and capillary telangiectasias, they often have a relatively benign course. I'll be going over them pretty quickly. So most of the time will be spent on the first 3 listed here. So if you feel like it's going to be dragging, don't worry, it's going to pick up the pace really quick. So we'll go over the clinical presentations, the imaging, and like I said, summarize the broader concepts behind what guides or factors into their management and some of the interventional decisions. And for a lot of these, I'll actually, before going into the text and the clinical presentations, I'll be showing a lot of pictures just to kind of add some imagery context to what I'll be talking about, which I think is helpful when learning these things or reviewing these things. So starting with AVMs. So brain AVMs are high flow vascular malformations, and they're composed of these large feeding arteries, these draining veins, and then also this structure in between that's this nest-like structure called the nidus that actually connects those feeding arteries and draining veins. And the nidus consists of these complex shunting arterioles and interconnecting venous loops that on neuroimaging look pretty impressive and almost look like a bag of worms, if you will. To me, the nidus is really impressive on imaging and is what most readily differentiates it from the other malformations. An AVM nidus is often fed by 1 or more arteries and drained by 1 or more veins. And AVMs lack intervening capillaries. And the importance to that is that it's a much lower flow resistance system. So it's actually a much higher pressure system where that venous side is going to be experiencing that arterial pressure. Etiologically, we don't know why they form, but they have been traditionally considered to be congenital lesions, kind of formed in gestation, thought to be formed in the first trimester. That being said, there are several reports out there of de novo AVM formation after things like radiation therapy. So the picture is not quite 100% clear. Like I said, they generate these very high arterial pressures, and they are uninterrupted as the blood traverses into the draining vein. And there are consequences of that, including arterialization of the venous structures. You can get enlargement of feeding arteries because of that lower resistance. And you can also develop these like flow-related aneurysms along the feeding arteries as well as the nidus. It also tends to give the veins this like very robust and tortuous appearance that makes them more identifiable on imaging. It's also what makes them ultimately more vulnerable to rupture and hemorrhage, which is the most serious complication. So in terms of imaging, symptomatic patients coming to the hospital are most likely to start with a non-con head CT. And this is obviously going to pick up large enough symptomatic hemorrhage, but it's frequently going to obscure the AVM as well as its nidus. That being said, the nidus itself is often somewhat hyperdense compared to the adjacent brain parenchyma. And if you do have a post-contrast head CT that's available, the abnormal vessels are usually much more evident. So on a CTA head, for example, on an arterial study, you can often readily identify the main and larger feeding arteries, as well as some of the draining vessels, and then that kind of like bag of worms appearance of the AVM nidus. But the CTA overall, while it identify those big vessels, is not going to have that spatial resolution to delineate just the full extent of the AVM architecture, which is really important eventually when we talk about management. MR imaging is highly sensitive for detecting an AVM. You're going to see these very dark, prominent phleboids on T1 and T2 weight imaging. Again, because of that high flow shunting nature of AVMs. An MRA head study, usually in conjunction with gadolinium administration, is very sensitive or specific. And interestingly, time of flight studies aren't bad for picking up the presence of a nidus, but it's going to be limited if you're going to be relying on a time of flight to look for those feeders and draining vessels. So if you can, just go with the contrasted gadolinium study. And then unsurprisingly, the gold standard for diagnosis and evaluation is a catheter angiogram. So a catheter angiogram plays a critical role in preoperative neurosurgical planning. If you're going to be doing stereotactic radiosurgical planning, it's also really important post-operatively to make sure that you've obliterated the AVM that you want to obliterate. It's going to give the best spatial and temporal resolution, and it's going to readily delineate all those feeding arteries and draining veins, as well as any early draining veins or any associated aneurysms. And those are important to identify because we'll go into it in a later slide, but those are actually associated with an increased risk of hemorrhage. The angiogram is also going to give you just a sense of the flow state of the lesion, because you can actually even just visualize and I think quantify. I'll defer to the neurointerventionalists on that, but I think you can quantify the degree of AV shunting as well. So enough talking about it, let's jump into several imaging examples. This is a patient with a left parietal lobe intraparenchymal hemorrhage evidenced by the non-con head CT on panel A on the very left there. And as you can see, extensive intraventricular hemorrhage as well. On panel B in the middle is a red arrow that's pointing to this like prominent hyperdensity in the left parietal lobe that kind of raises concerns for something more going on besides just the bread and butter intraparenchymal hemorrhage with ventricular extension. Again, the hemorrhage will often obscure the AVM, but the AVM nidus can often appear hyperdense, as is the case here. And on panel C is the CTA of the head, which more clearly outlines that previously identified abnormality with that kind of bag of worms appearance, the friendly yellow arrow sign on the very right. This is the same patient's same AVM and bleed, and panel D is the coronal view, and the arrow is basically pointing to this large draining vein that's actually heading to the superior sagittal sinus. And remember that AVMs are high flow AV shunts, so you're actually seeing here contrasted blood get picked up in the draining vein and ultimately going into the superior sagittal sinus, despite this obviously being timed as a CTA study. Panel E in the middle is a sagittal nip reconstruction, and the ever-friendly purple arrow sign is pointing to this feeding artery that is presumably coming off the left middle cerebral artery. And panel F goes back to the axial source images of the head CTA, and the white arrow is pointing to this draining vein that's presumably exiting from the nidus and is going to one of the deeper veins. I think probably the vein of Galen or internal cerebral vein down the left. Not 100% sure. But certainly, the point being, for a lot of the CTA studies, you can identify the nidus location and oftentimes a lot of the major feeding and draining vessels. Different patients, 66-year-old man with an acute right frontal intraparenchymal hemorrhage. And panel A on the very left shows the CTA of the head. And along that lateral margin of that hemorrhage, you can kind of see this tangled contrast-enhancing vessels that suggests an underlying malformation. And panel B on the right shows the corresponding cerebral angiogram. It's a little bit of a weird angiogram. So the bleeds in the right frontal lobe, and presumably normally would go through the right common or right internal, but this is actually a run through the left vert because the right side was occluded. So you're actually seeing contrast making its way through the left vert, through the PCOM, and then going to the other side, and seeing the superior branch of the M2 kind of fill out there. And what you're seeing is actually these M2 branches, the preorbital and orbital frontal branches, as pointed out by the white and black arrows, they're feeding into this nidus that's kind of subtle. But the larger, longer arrowhead is actually pointing to the nidus, with the more dense regions there actually pointing to some associated aneurysms on the nidus or at the tail end of those feeding arteries. And then the curved arrow at the very end there in white shows basically what is probably a dilated cortical vein that I think is just going back to the superior sagittal sinus. Another patient, a 54-year-old woman who presented with a left-sided weakness. The non-con head CT on the left, panel A, shows this kind of subtle but hyperdense lesion in the right frontal lobe that you might scroll through initially, but definitely is there and kind of catches the eye. And panel B is an MR time of flight reconstruction that shows an AVM with the arrow pointing to the nidus. That's subtle, but if you kind of look at it, you can see this kind of like bag of vessels there. And it looks to be in between the MCA-ACA border zone and is getting distal feeders from the MCA and ACA. And panel C is the contrast enhanced MR. It's using a gadolinium-based blood pooling agent that since is no longer being made in production, but it's like this higher, more paramagnetic, provides better resolution in outlining the nidus, and essentially confirms our suspicion based on the preceding imaging. And then the last example shows flow voids on MR being helpful to pick up these AVMs. So this is a 55-year-old man with an unruptured left medial temporal lobe AVM. This is the axial T2 sequence. And you can see these arrows pointing to these very prominent flow voids around and within the AVM nidus. And the short arrow is pointing to this enlarged left PCA segment that's kind of hugging the midbrain along the left cerebral peduncle. And the long arrow kind of pointing to what is probably a draining vein leaving the nidus, which is pretty neat. So a lot of imaging, and now jumping into the clinical presentation. So as we all know, brain AVMs can present with intracranial hemorrhages, which is often the most devastating consequence. And the risk of untreated, unruptured AVMs is estimated to be about 1 to 3% per year, based on an abundance of case series and observational data. They can also present as focal onset seizures, especially if the AVMs are larger and cortically based. And thirdly, they can potentially exert what's hypothesized as a steal phenomenon, where you're getting all this like high arterial flow into these large feeding arteries without much resistance, and it's diverting blood away from neighboring capillary beds. And this is thought to maybe play a role in some folks who have focal deficits. And finally, as is the case with all of neurology, headaches are pretty common, as one might expect. So let's jump into management, starting with ruptured brain AVMs that have already bled. So generally speaking, the recommendation is to consider intervention options at this point. And this is based on a plethora of observational data that shows that a prior rupture is the most consistent risk factor for recurrent hemorrhage. The presence of other risk factors for hemorrhage, which I'll go into later, might also push you more aggressively towards early intervention. Some exceptions might be those who have like an unacceptable, generally speaking, risk of surgery because of comorbidities, if they have a short expected life expectancy, or just like technical considerations behind our various intervention options. And the timing plays a role here, which I learned on my time in the neuro ICU and in my last couple rotations there. So basically AVMs, with high risk angiographic features, again, which I'll go into later, they're more often considered for acute treatments, but otherwise, a lot of times the hematoma of a ruptured AVM is allowed to quote unquote mature and just start some of that absorption process, and also let some of that surrounding edema kind of chill out a little bit. And these things can actually help with surgical access. I'm not a neurosurgeon, I wouldn't know from personal experience, but from what I've read, it helps with surgical access, as well as accuracy of targeting during stereotactic radiosurgery. That's the avenue of treatment. For unruptured brain AVMs, it's more complicated and kind of goes on a case-by-case basis. So generally speaking, it's going to start with conservative management, and that has at least in some part to do with the Aruba trial, which certainly goes on my short list of favorite names for clinical trials, but was a randomized controlled trial comparing medical management versus medical management with intervention in the population of folks who have an unruptured AVM. And the providers in the study had a lot of flexibility in terms of deciding among the various intervention options, surgery, radiosurgery, and/or endovascular embolization. And the results of that study suggest that interventions for unruptured AVMs are not beneficial and may actually be harmful. And while it is randomized data, the Aruba study was far from a perfect trial and got quite the spearing from the medical community, got a substantial amount of criticism. So Dr. Ariel Davis, my program director for my fellowship, actually sent me this very neat systematic review that was published in the Journal of Neurosurgery of the numerous papers and editorials criticizing it. Just a few of the prevalent critiques were that there was just an utter lack of a standardized treatment arm. There was a high degree of recruitment bias in terms of kind of taking folks who they thought were more amenable for surgery. And then there was also just a very short follow-up period that didn't quite track out the effects of either arm as long as would like in terms of follow-up in terms of patient years. That being said, it is one of the very few randomized clinical trials that we have in this vascular malformation kind of literature body that at least suggests a starting point to consideration of conservative approaches. So it's a case-by-case basis. And there are situations where elective surgery might make sense. If you have a symptomatic case a symptomatic case that's low risk, like someone who has refractory seizures, that might be a case, for example, that might push you to intervene on an unruptured brain AVM. So going into what those risk factors are beyond just having a prior hemorrhage. So a couple of meta-analyses offer insight on this. And like I mentioned several times already, hemorrhage as the initial clinical presentation seems to be the strongest predictor for subsequent hemorrhage in untreated brain AVMs, with the annual risk, like I said, about 1 to 3%. But that risk is nearly doubled if there is a prior rupture or hemorrhage. Increasing age at diagnosis was another risk factor identified in one of these meta-analyses, and the risk seemed to increase by about 30% per decade. And then lastly, there are certain AVM like structural and angioarchitectural features that might associated with an increased risk of hemorrhage, specifically if it has exclusively deep venous drainage, if it's at a deep brain location, and if there are associated aneurysms. And interestingly and notably, size was not actually associated with hemorrhage risk. So along those lines, categorizing AVM patients by the number of risk factors they have may actually help give a sense of their annual risk of rupture. So we have data from the Columbia database that looks at 3 risk factors: hemorrhage at initial AVM presentation, whether it had deep venous drainage, and whether it was in a deep brain location. And they tried to see what the associated risk was as a function of the number of those 3 risk factors they had. And as you can see, the more risk factors you had, the greater the percentage of an annual rupture. And so there are these kind of schemes out there to kind of help kind of risk stratify folks. On the left, table 1 is the well-known Spetzler-Martin grading scale, which helps classify the risk of AVM intervention by AVM size. And kind of makes differentiations based on whether the AVM is in an eloquent versus non-eloquent brain area, whether it's a deep venous drainage that's present. And they defined eloquent areas pretty intuitively. It was in an area in the cortex that involved the sensory motor function, visual function, language function. Deeper structures were defined as things like the internal capsules, the basal ganglia, the thalami, the brainstem, the cerebellar peduncles. And in the deep venous drainage really was just defined as if any or all of the outflow of the AVM entered the deep veins, like the internal cerebral veins. And table 2 on the right basically highlights that the higher Spetzler-Martin grading scale you have correlates with an increased risk of microsurgical and radiosurgical morbidity and neurologic deficits. So, generally speaking, the higher the grade, actually, the more conservative approach is generally taken. And dividing into treatment options, so the first is open microsurgical excision, which has the longest standing history of use for quote unquote definitive treatment. It has the best chance for kind of immediately addressing concern for hemorrhage risk. It's a very technically complicated surgery that just requires a lot of detailed planning and review of the available imaging. And it's going to lead to the most immediate addressal of trying to obliterate the nidus and to try to address or reduce the risk of hemorrhagic risk with the AVM potentially rupturing. But it does have disadvantages, as you might expect. It's much more invasive than the other 2 options I'll talk about. It risks incurring neurologic impairments because you might be dissecting normal brain parenchyma. You might be traversing deep fiber tracts if it's a particularly deep AVM. And you might actually nick a normal neurovascular structure and might cause a bleed and neurologic injury that way. The second option listed here is stereotactic radiosurgery, which is most successful for treating small brain AVMs. And it basically uses very focused beams of protons, generally speaking, to define volume in the brain AVM, and it's trying to induce progressive thrombosis. And the important thing to know about radiosurgery is that it usually takes 1 to 3 years, sometimes longer, for this obliteration process and thrombosis to occur and for effective treatment to take place. So, during this latency period, your patient's actually going to remain, theoretically at least, at risk for hemorrhage. And then the last approach, embolization via an endovascular approach, isn't as effective as a monotherapy for, say, obliterating the AVM, but it plays a critical role adjunctively. So it involves injecting these microparticles or embolization material into the AVM, and that just helps, whether it's prior to surgery, it may help reduce blood loss or occlude vessels that they might anticipate would be difficult to control during surgery. It can also be used to treat intranidal associated aneurysms prior to going in there microsurgically. So with that all being said, it's really a multidisciplinary process, and cases need to be discussed, among different specialties. And it also just depends on the specific AVM you have on hand and the risk factors and the different angioarchitecture you might see with the preceding angiogram. So in summary, AVMs, they are these anomalous high flow AV shunts that, in my eyes at least, are really distinguished by the presence of this intervening nidus. Really, CT MR can pick it up, but the cerebral angiogram is your gold standard for diagnosis as well for just planning prior to an intervention. And the management is really going to be tailored to the individual patient based on risk factors and our understanding of the natural history of ruptured and unruptured AVMs. And as we discussed, the treatment options are some permutation of microsurgery, radiosurgery, and endovascular embolization. Okay, so moving on to dural AV fistulas, and no worries, that was the densest section. It all kind of progressively gets shorter, and then the last two are very short. So moving on to dural AV fistulas. So dural AV fistulas are abnormal connections between the arteries and either a dural sinus or a cortical vein. And to emphasize, this connection actually occurs in the dural leaflets, hence the name dural AV fistulas. And like AVMs, these are also high flow, low resistance vascular malformations because they're a straight shot really from the arteries into the veins and are really, like AVMs, experiencing that high arterial pressure. But the distinction really being that these fistulas don't have these complicated, nasty-looking niduses that AVMs have, like I just mentioned. The etiology of dural AV fistulas is unknown, but they're thought to be acquired rather than congenital. And there is a pretty well-known association with dural AV fistulas and having had venous sinus occlusions or stenoses, though the exact mechanism that drives that pathophysiology is unclear. In terms of diagnosis and imaging, non-invasive CT and MR modalities are first line, and they can demonstrate symptomatic dural AV fistulas, obviously, when there's hemorrhage or associated edema. But with nearby hemorrhage, it can be pretty difficult to appreciate. But there are some suggestive signs. So you might notice an abnormally enlarged or tortuous vessel, or an abnormally large and arterialized venous sinus in the contrast phase of an angiography study because of that high flow AV shunting through that fistula. Cerebral angiograms are the gold standard for detecting these, and when you're evaluating them, you really just want to get the full shebang. You want to get bilateral runs in the carotids, internal and external, as well as in both verts. The hallmark of dural AV fistulas is the presence of early venous drainage because of that high flow fistula. A catheter angiogram is also just going to most clearly outline the fistula location, all of the arterial supply, and the pattern of drainage. And the pattern of drainage is actually really important here for risk stratifying these malformations, which I'll go into shortly. So let's jump into a few examples. So this is a patient with a right sigmoid dural AV fistula. And on the left, panel A is an axial CTA with the helpful long white arrow there, pointing to an enlarged right occipital artery, which, if you remember, the occipital artery is an artery that comes off the external carotid pretty early on. And in the middle, on panel B, is the corresponding cerebral angiogram for that same patient. And this is a right external carotid artery contrast injection. We're looking at the lateral projection. And you can see, actually, as pointed out by the black arrows, this like markedly enlarged occipital artery that's normally not that prominent. And that we also saw on the previous CTA of the head. And the smaller white and black arrows are pointing to these kind of transosseous feeders that are contributing to the fistula. And again, on panel B, you can actually see that feeding artery kind of make its way towards the sinuses. And in panel C, going back to the axial CTA, you can actually see this like very enlarged, weird looking right sigmoid sinus that's enlarged, it's very irregular appearing, and presumably is getting that drainage. This is a different patient that highlights, I think, the utility of MR and just always looking for these prominent flow voids. So on the left with panels A and B are these two T2 axial cuts, and on the right, panel C is the corresponding cerebral angiogram. And panels A and B show these very large vascular flow voids that really shouldn't be there in a normal patient. They're kind of hovering around the floor of the left anterior fossa. And these prominent flow voids are there because, again, these AV fistulas are high flow, low resistance lesions. And so the blood flow is moving fast, the MR is not going to pick up signal from these vessels. So panel C on the very right shows the corresponding angiogram, and you're actually seeing contrast being injected through the left common carotid artery, and you're seeing that dural fistula. It's being fed by these branches coming off this very prominent ophthalmic artery that's kind of being pointed out by the black caret arrows at the bottom there. And then the asterisks are pointing to the, or at least sitting on, I should say, the cortical frontal veins that are draining the fistula. And as you can see, they've just become very markedly enlarged and arterialized due to that high pressure flow from the arterial system. This is an interesting case, a patient presenting with rapidly progressive dementia. And on panel A on the left is the axial T2 flare. You're seeing these hyperintensities in the bilateral thalami that are, in retrospect, edema related to venous congestion. And this is actually a dural AV fistula that's draining into the vein of Galen. And on the right, again, is the corresponding cerebral angiogram, lateral view. And it's again an injection in the left common carotid artery. And it shows the dural AV fistula being fed once again by the occipital artery, shown by the black arrowheads. And you're seeing that early AV shunting into the deep venous system through the vein of Galen, which is marked by that lone asterisk there. And so we'll talk about this shortly, but cortical vein drainage actually portends a higher risk of hemorrhage and neurologic deficits, and might actually push you to intervention more aggressively and acutely. And we don't have the post-treatment images, unfortunately, but according to this paper, this patient underwent endovascular embolization of the fistula and had complete obliteration of the fistula and had complete resolution of both the clinical cognitive deficits as well as the radiographic findings on MR. So in terms of clinical presentation, symptoms depend on a couple of things: the fistula's pattern of venous drainage, and then two, their location. So we'll start with venous drainage pattern, and those with antegrade, essentially forward flow drainage into these larger caliber venous sinuses, the symptoms are generally pretty mild, and it could range from being asymptomatic to maybe some headaches or maybe some pulsatile tinnitus, depending on where it's draining. But if the fistula has sinus drainage and there's retrograde flow, say because of venous backflow, because there's congestion, or because there's stenosis in these larger sinuses, and you just can't get that blood flow through, you can actually get more serious processes, like, for example, that rapid cognitive decline in that previous patient. Some folks may present with almost like a pseudotumor cerebri picture. And it can get even worse. If you have these fistulas with really just pure cortical vein drainage, as opposed to directly into these larger caliber venous sinuses, that really increased the risk for serious sequelae like hemorrhages, venous infarcts. Depending on the location, you can get seizures if it's in the cortex, or Parkinsonism, for example, if you're kind of affecting the basal ganglia. So it can be pretty profound if the plumbing doesn't allow an output for that high arterial flow. And like I said, location is the second component to the clinical presentation. So, for example, pulsatile tinnitus, which we all know is associated with dural AV fistulas, tends to be when the fistula is close to the auditory apparatus. So if the fistula is like in the middle fossa somewhere and it's draining into sigmoid and transverse sinuses, you're more often going to get pulsatile tinnitus. Another example is vision symptoms. If you have someone who has a cavernous sinus fistula because of arterialization of the ophthalmic draining veins, you're going to get congestion. People can get this very prominent exophthalmos and you can get visual impairment. And then fistulas in the anterior fossa, like I showed earlier in the images, or ones that are in the tentorial dural AV fistulas, they tend to be more likely to bleed because that location intrinsically tends to drain into those cortical veins that are just lower caliber and can't handle that pressure and amount of blood flow. There are a myriad of classification systems out there for these fistulas, and these are the two that make the most frequent cameos. I won't go into the details, I don't think that's the important point here, but the Borden classification has these three categories as a function of whether they're draining into a big sinus or whether it's going into a small cortical vein, and then whether it's forward flow antegrade drainage or if there's actually retrograde drainage. And then the second one, the Cognard classification, is essentially the same kind of first principles, but have a little more detail, like, is there venous ectasia present? And again, not worth going into the details specifically, but the point being that the higher the classification, the increasingly aggressive it's thought that the neurologic course is going to be. And these different classifications, they can actually help organize the different types of dural AV fistulas by their corresponding natural history and their risk of bleeding, especially if you combine them with their draining patterns and their clinical symptoms. And so we'll break this down. So on imaging, you can look for their primary form of venous drainage, whether there is the presence of any cortical venous drainage or cortical venous congestion. And then you can look for the presence of associated intracranial hemorrhage or non-hemorrhagic neurologic deficits. And then you can correspond that to the associated ICH risk and risk of death based on the observational studies that we have in the literature. And this can actually help make a treatment recommendation, at least depending on the guideline that you're looking at. So this is a really busy chart. It's not worth going through in detail, but within all of this, basically, there are two types that are associated with the highest ICH risk and death risk. And these are ones that guidelines recommend generally for early as opposed to like an elective or observational approach. And basically the point is that there are these symptomatic dural AV fistulas that have cortical venous drainage and are symptomatic. And these are ones you really just want to get on top of early and intervene. There's certainly more nuance to this, and I'm not a neurosurgeon. This is just based on my literature review, but obviously it depends on the patient and the specific details you have in front of you. Yeah. So in terms of management options, low risk ones lend for conservative management, but if an intervention is needed, most cases can be addressed by endovascular embolization. So while surgical and radiosurgical approaches may play a more adjunctive role, it's really going to be endovascular, and it's kind of the opposite of AVMs. Endovascular approaches can be done transarterially or transvenously, but the other two can play an adjunctive role or be employed if endovascular approaches don't work out, basically. So in summary, dural AV fistulas are these abnormal connections between arteries and a dural vein or sinus, and their clinical presentation can range from asymptomatic to something benign like pulsatile tinnitus to something very severe like intracranial hemorrhage. And the natural history and the clinical presentation really is influenced by the pattern of venous drainage and how they're presenting initially. And treatment is generally speaking going to be endovascular embolization. Cool. All right. So you guys are hanging in there with me. We're going to move on to CAV-MALs. And again, this is going to move quicker and quicker. So they go by several different names. So cavernous malformations are also called cavernomas, cavernous angiomas, cavernous hemangiomas, all referring to the same thing. And unlike the previous two, CAV-MALs are low flow lesions with venous pressures. So they are often accompanied actually, and interestingly, by the fourth vascular malformation we're going to talk about, developmental venous anomalies. They kind of almost tag along like a buddy with them. And interestingly, in the era of these higher Tesla MRI scanners, 7T scanners, we're actually picking up these DVAs more and more frequently. What CAV-MALs are basically, they're these like endothelium-like cavities that just kind of have blood like slowly flowing through them. We're sitting there just of all different ages. And structurally, they lack these like tight junctions. And so it leads to this like dysfunctional kind of seal, and you get this leakiness of blood into the surrounding area sometimes, and microhemorrhages, and that's what contributes to some of the clinical manifestations. They can occur sporadically or in a familial pattern. Familial cases account for about 20% of cases, and they often have like many cavernous malformations at once, often have very impressive imaging. There are known pathogenic variants, for example, the CRIT1 variant being the culprit frequently in Hispanic American populations. And really, if you have someone with multiple cranial CAV-MALs or someone with a family history of CAV-MALs, you want to consider sending them for genetic testing. Sporadic cases, they tend to be associated with a DVA, and they tend to present as solitary lesions. And in terms of imaging, MR is actually the modality of choice. CAV-MALs on MRI will have this very characteristic kind of popcorn appearance that we all kind of remember from our boards on T1 and T2 weight imaging, and that just reflects the variable intensities basically reflect the various ages of the evolving blood products in this slow flow, low pressure state. You can sometimes see surrounding edema on T2 flare, and that might suggest a little more activity or bleed from that CAV-MAL. Gadolinium contrast is not super reliable. You can sometimes get variable enhancement and this like kind of mottled appearance, like speckled appearance. But it's still worth getting a contrast study because you may be able to pick up a developmental venous anomaly, which tends to show up pretty well on a post-con T1. And that would be important, picking up the DVA for surgical planning because, we'll go into this later, but if you resect the DVA, you might compromise the venous drainage of that system and actually cause venous infarction. CT imaging, very limited. Cavernous are very difficult to see unless they're large. Sometimes they can be a little bit more hyperdense, but it's not super reliable. And similarly, catheter angiography, unlike our first two, is not very helpful here. They tend to be occult because they're slow flow and they don't demonstrate any AV shunting. So generally, you're not going to be getting an angiogram unless the imaging is kind of uncertain. And if you're thinking about like an AVM or something instead, then you want to get it to clarify the diagnosis. So like the first two, let's jump into imaging examples. This is a patient with a Cavernous in the right cerebellum. And on panel A in the top right there, you can see these like subtle speckles of hyperdensity in the right cerebellum. That suggests something there. Honestly, when you're scrolling through it, you might not make much of it, but it does kind of catch the eye. And panel B on the top right is a T1 sequence that shows this like rim of hypointensity, but internally has this like heterogeneous signal. And panel C on the bottom left is a T2, which basically shows the same. SWI sequence on the bottom left on bottom right, on panel D is the blood sensitive sequence and basically shows blooming of that Cavernous. And really on the T1 and T2, what you're seeing is just that blood product that's all various age. You're seeing that more chronic, dark signal that you often will see with chronic appearing blood on MR, but inside it's heterogeneous because there's blood kind of sitting there, maybe some of it's leaking out. So that's why you see that heterogeneous signal. Another set of MRI sequences, again, MRI is the diagnostic test of choice for Cavernous. And on the top left in panel A is an axial T1 without contrast, which shows this subacute blood around the Cavernous in the patient who developed right-sided hemiparesis acutely. Panel D is the T2 late sequence that shows this very kind of characteristic, like reticulated popcorny appearance with that hypointense hemosiderin surrounding the lesion. Panel C on the top right is actually a different patient. On SWI, you're just seeing a ton of blooming lesions showing multiple Cavernous. And this is what I was referring to as like, someone you might suspect with having that familial variant. Panel D on the bottom left is a T1 post-contrast enhanced sequence showing a Cavernous. You can actually see that pretty neat like DVA associated with it that's kind of piggybacking. You can see that collecting vein with the radial veins, that kind of classic caput medusa appearance for DVAs, which we'll go into next. And in panel E, in the middle on the bottom row is the contrast enhanced T1. And you are seeing some like mottled appearance of enhancements in that Cavernous, which is not super sensitive, but it does happen to be the case here. Panel F on the bottom right is the SWI sequence, and you're basically seeing a Cavernous with another associated DVA, kind of this like caput medusa hats kind of sitting on top of that Cavernous there. So in terms of clinical presentation, so supratentorial Cavernous can present with hemorrhages, seizures, and progressive neurologic deficits. The annual bleeding rates range from 0.25 to 1.1%, depending on the case series you look at. Seizures and progressive neurologic deficits are thought to be related to like compromise of the surrounding circulation or just straight out rupture. Cavernous infratentorially can present with a more dangerous course. If it's in the brainstem, obviously you might expect cranial nerves or nuclei affected. You may see long tract signs. And those in the infratentorium, they have a higher risk of bleeding about 2 to 3% per year, but the recurrent hemorrhage rate is actually pretty high. Again, variable depending on the case series you look at, but can approach 17 to 21%. So in terms of management, starting with asymptomatic Cavernous, they are typically found incidentally, and generally these are observed regardless of location. They're typically followed up annually, and some experts kind of advocate annual follow-up, but certainly more urgent re-imaging if there's development of new symptoms. A surgical resection can be considered in asymptomatic cases if they're easily accessible and in non-eloquent areas, especially if you have a patient who just has certain characteristics that might, whether it's related to a job or, needing to be anticoagulated, or just has like very substantial psychological burden from knowing about a Cavernous. those are cases where written about can consider intervention. For symptomatic patients, generally, if they present with seizures, you're going to be trying anti-epileptics first, but if refractory, that's when you might consider surgical resection. And for intracranial hemorrhage, the guidelines that I've read, some recommend it kind of depends on just where the canal is. If it's supratentorial and accessible, you would always consider resection in that case, depending on the context. If it's deeper, some guidelines recommend actually conservative management initially, but if it rebleeds again, you might be pushed towards considering surgical resection or stereotactic radiosurgery. So in summary, the cave mouths are these endothelium-lined cavities. They contain blood of different ages. They are low-flow vascular malformations that are often associated with DVAs. MR is the modality of choice. You're looking for that mixed T1 and T2 signal with that kind of popcorn appearance. And your blood-sensitive sequence is frequently going to show blooming of these lesions. Generally, asymptomatic lesions are observed, while symptomatic lesions are considered for resection, especially if they're accessible. Okay. Home stretch. So these two are quicker. So fourth on the list are developmental venous anomalies, or DVAs for short. DVAs, like cave mouths, go by many names. Venous angiomas, venous malformations, or venous medullary malformations, they're all referring to DVAs. And they are just basically this like confluence of these like radially oriented veins that all kind of converge into this single dilated venous channel. And you can sometimes even just pick them up as a hyperdensity on a non-contrast head CT. The natural history based on the observational data that we have suggests that they're almost always benign unless they're associated with a cavernous malformation, in which case they may bleed. And the trigger for the development of these is unknown, but most theories revolve around the idea that there's like altered venous drainage during fetal development, which prompts the formation of these. This is a schematic of a cerebellar DVA. They're kind of these like neat, cute looking things, like small vessels that converge. In this case, they are converging and eventually going into the straight sinus there. On imaging, you can, like I said, sometimes appreciate it on non-con, but not super reliable. You might incidentally pick this up on contrast administration, and they'll kind of come as like this linear or curvilinear enhancing structure. And on MR, they're most easily actually appreciated on a post-con T1. They also have susceptibility on an SWI. And the SWI is important to get because that actually is going to help you kind of pick up an associated cavernous malformation, especially the smaller ones. The gold standard for diagnosis is a cerebral angiogram, which will also show that caput medusa appearance in the venous phase, which is pathognomonic. Jumping into a few examples here, panel A on the very left is a T1 sequence with a contrast study showing a left cerebellar DVA. You can see that kind of caput medusa appearance spanning out towards the midline. Panel B and C shows the sagittal and coronal views of the CTA. That similarly shows that DVA with that caput medusa appearance. So again, you're seeing those radial veins are kind of draining into that larger collecting vein. This is a patient with a right frontal DVA, and shown on the brain MRI, panels A and B on the top show flow voids that indicate the draining vein, and panel C on the bottom left is a post-con T1. You're actually seeing enhancements of that radial draining vein. And bottom right on panel D is the corresponding angiogram. You can see that caput medusa appearance, excuse me, draining into what's probably the sagittal sinus there. This is an interesting case of a patient with a thrombosed left frontal DVA, and panel A on the very top left there, on the head CT, like I said, you can sometimes pick it up, and over here you can actually appreciate an abnormality there, suggesting a possible DVA. Panels B and C shows the shows the flare and T2 respectively of that DVA, and interestingly, you see some surrounding edema around it, which isn't normal for DVAs. And in panel D on the top right is the blood sensitive sequence that I think is a GRE, if I'm remembering from the paper. And it does show signal dropout as you would expect for a DVA. And then E on the bottom left is a post-con coronal T1. And you see that DVA pretty clearly. But interestingly, you can actually appreciate this like subtle filling defect in the collecting vein. And so this patient actually has a thrombosed DVA. And the patient was started on anticoagulation. Panels F, G, and H show the follow-up studies. F and these are the MRI T2 flare studies, basically showing resolution of the associated edema we saw earlier. And then when you look on the very right bottom on H, you're showing that post-con T1, which shows resolution of and recanalization of that collecting vein, which is pretty neat. DVAs are widely accepted as having benign natural histories. There's a myriad of observational studies to support that. There's a very low annual risk of hemorrhage. And even then, for those bleeds, they tend to be associated with ruptured cavernous. There are reports of DVAs associated with seizures, although there's not a clear causation to that. And it's kind of controversial depending on where you read about seizures and DVAs. There are rare reports, like I just mentioned in the blast imaging, of these DVAs thrombosing, but these are rare, and there's anecdotal evidence of treating it with anticoagulation. Given the overall pretty benign natural history, the management is conservative. You just kind of treat these associated headaches or associated seizures if they rarely come up. And like I mentioned earlier in the cavernous section, surgically obliterating these is tricky because if you do that, you kind of risk removing the venous drainage source for that venous system, and you may actually end up causing venous infarction. And so that, in conjunction with what's thought to be a benign natural history, people opt to not intervene on these. And there's no defined role for radiosurgery or endovascular approaches for DVAs. So in summary, they are these confluence of radially oriented veins into a single dilated venous channel. They are generally benign, although rarely associated with seizures, although it's unclear about causation. Hemorrhage tends to be associated when there's an associated cavernous. They are readily identifiable on contrast vessel imaging as well as contrasted MR, though cerebral angiogram is the gold standard. And treatment is generally conservative for the reasons I just mentioned. All right. And finally, and very briefly, capillary telangiectasias. So these are small, benign, asymptomatic, low-flow lesions that they're basically like these small capillaries that are dilated, and they structurally are abnormal. They lack or have dysfunctional smooth muscles and elastic fibers. And they are interspersed in healthy normal brain parenchyma, in contrast to like cavernous, which are just these cluster of venous channels that don't have any intervening parenchyma. They are almost always located in the pons and cerebellum, and usually solitary, although there are reports of multiple. And there's mention in the literature, it's kind of interesting, that maybe these are like an early stage of like certain mixed vascular malformations or even cavernous malformations, although that's still being kind of clarified. And in terms of imaging, MRI is the most sensitive modality. Actually, before the advent of MRI, it really wasn't widely recognized, but folks started picking it up more once MRI became more clinically used. Capillary telangiectasias aren't really seen on CTs and usually aren't picked up on cerebral angiogram, although angiogram sometimes you can identify this like faint blush in the arterial or early capillary phase. Unlike DVAs, in contrast, which usually are picked up in the venous phase of an angiogram. So over here, this is a case of a capillary telangiectasia in the pons on the top left axial T1. It's pretty subtle. I would say it's iso-intense, but at least in certain articles in Radiopedia, will say that you can see sometimes a low signal change, which I don't appreciate here. But on T2 flare, similarly, you can sometimes see a subtle change that's hard to pick up. But you can more oftentimes sometimes see T1 post-contrast changes. You'll see enhancement, particularly if it's a larger capillary telangiectasia. And sometimes you can even see like a branching linear draining vein. On T2 star weight imaging for a blood sensitive sequence on like an SWI, as in the case here, you can't see low signal there because of the sluggish flow going through these abnormal channels. This is a capillary telangiectasia seen in the pons. So we're looking at the GRE and the SWI, but it's basically also correlated on the post-contrast T1 sequence. You can see kind of a subtle vessel there. And unsurprisingly, the SWI being a little better at picking it up than the GRE. Clinically, these are silent lesions. They are found incidentally on neural imaging. And there's a tiny meta-analysis of like 10 case series of about like 200 or so patients with capillary telangiectasias, and just kind of tracking for like what symptoms they develop. And these patients have pretty non-specific symptoms like headache, nausea, and seizures, although again, pretty non-specific and very unclear if there's a causal relationship to that. So overall, pretty benign course is how it's thought of. And so a lot of that, again, management is conservative. They aren't really appropriate for surgical resection anyway, because like I mentioned, just the way they're structurally generated, they are interspersed between normal brain tissue. So it's pretty high risk for surgical removal, and also, in a high stakes real estate area in the pons. So in short, capillary telangiectasias are low flow venous pressure, low flow vascular lesions. They consist of dilated capillaries between normal brain parenchyma, typically in the pons and the cerebellum. MR is the most sensitive imaging modality, and they have a pretty benign natural history. And because of that, the management is conservative. So that wraps it up. We covered 5 vascular malformations very quickly. Hopefully I didn't talk too fast. But hopefully this was a helpful refresher for pathology that we encounter not infrequently, and that we should always be vigilant about, considering how many bleeds we see at Harborview in our stroke codes. And again, these are shunted towards our neurosurgical colleagues very quickly, but I think just having at least some general kind of first principle understandings of how to identify them, how they present, and what might constitute higher risk based on natural history and observational data. I think just having an intuition of that is helpful, especially if we are dealing with this in the inpatient setting, dealing with head bleeds. So with that, thank you for your attention. I'm happy to take questions, although I'm definitely going to raise the card of I'm not a neurosurgeon and don't have a lot of practice intuition, but happy to try. This is a colorful sunset in Hawaii, I think providing some sun and warmth as we traverse out of our Seattle winter, which I happily corrected Dr. Coe today on rounds is actually March 20th is the end of winter. It looks like we have pretty good weather today, so maybe it's not needed, but yeah, thanks for your attention.
Great, Will. Thank you very much. And I'll open that for questions. There's a couple on the chat. One from Dr. Churchwell. Does retrograde drainage imply a sinus occlusion?
I think it can, and certainly I think if you have occlusion, you're probably more likely to see retrograde drainage, but I don't think it necessarily means that there is an occlusion. From what I was reading, and if there's any neurosurgeons out there who are interventionalists who may know better, please correct me anytime, but I think even just if there's just kind of a backup and congestion, you may not even need an occlusion. It could cause backflow that way. Or if it's going into like a smaller caliber cortical vein that just can't handle that volume and pressure, you might get antegrade as well as retrograde drainage. And certainly you can even see folks who have say a stenosis in the venous sinuses. You can, it's not necessarily occluded, but you can see drainage, retrograde drainage there as well, because you're just kind of literally bottlenecked in that kind of escape plumbing, if you will, if that makes sense.
Just along that line, Will, I've always thought of the AVMs as something you're probably born with, but dural AV fistula is something you might acquire. I'm not sure if you touched on that or not, but like as a consequence of trauma or venous sinus occlusion, is that an accurate description?
Totally, yeah. That's what I had seen as well, and there's a lot of interesting associations with dural AV fistulas, exactly like you mentioned, like trauma, folks who have a venous sinus stenosis or a history of a CVST, and there's also an association in some reports of having systemic venous hypercoagulabilities, like for folks. I can't remember which case series I saw. I think having factor V Leiden was associated with them. So you're totally right. It does seem like it's an acquired thing. AVMs are interesting. I think the traditional viewpoint was that these were all congenital. But and one of the papers I read, they brought up an interesting point of if they're congenital, why don't we pick them up on prenatal ultrasound? I didn't go into vein of Galen aneurysmal malformations, which people will debate whether it's an AVM or a fistula, an AV fistula, but those you can appreciate on prenatal ultrasound readily, but you don't really see them. You don't really see brain AVMs on prenatal ultrasound. So I think the traditionally held view of it being congenital, AVMs being congenital, is kind of being challenged a little bit, and there is some controversy.
Well, this is Tom Bird.
Yeah, hey, Dr. Bird.
Thank you very much. That was a superb overview. I really enjoyed it a lot. I just wanted to point out an interesting little clinical aspect of this is that some of the congenital and the familial cases have interesting skin and dermatologic manifestations. The classic is Sturge-Weber with the port wine nevus of the face, but also some of those familial cavernous angiomas and some of the familial telangiectasia syndromes can have skin manifestations that are a clue to who else in the family may have it. We once had a case that the dermatologist said on the skin had a blue rubber bleb nevus, which I thought was an interesting manifestation. But dermatology, these vascular malformations, when they're congenital and hereditary, can appear in other parts of the body.
Thank you, Dr. Bird. That's a super interesting point, and also a testament to systems that might give us clues here in these very interesting cases. Thank you.
Any other last minute questions for Dr. Liu? All right, well, I think we'll wrap it up. There's a lot of comments just pointing out that it was a great talk, and I think everyone agrees. So thank you very much for a great talk, Dr. Liu. And we'll do it again in a little bit. Thanks everyone for joining, and please do fill out your evaluations. Very important to get everyone's evaluations. Thank you.
Thanks, everyone. Thanks, Dr. Koch.
Goodbye.